Welcome to today's CanVector National Thrombosis Seminar. This is the last seminar of the academic year. My name is Joseph Shaw. I'm a hematologist and thrombosis medicine specialist at the Ottawa Hospital, and I'll be your moderator for today's session. Today's seminar is titled Working Towards Precision in DOAC Reversal Through Harnessing the Power of a National Trainee-Led Network in the UK. So just a brief reminder about the series. The CanVector National Thrombosis Seminars are hosted live throughout the academic year and feature state-of-the-art thrombosis and venous thromboembolism lectures from Canadian and international experts. Video recordings of the seminars are available online through the CanVector website. This seminar series is also a self-approved group learning activity. Section 1 is defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. I would also like to acknowledge the members of the 2025-2026 National Thrombosis Seminar Planning Committee. I'm the chair as listed here, and then the other members of the planning committee are seen listed here. Thank you very much to the committee members for their work in developing this year's seminar series. So our speaker today is Dr. Richard Buka. Dr. Buka is an academic clinical lecturer and hematology registrar at the University of Birmingham in the United Kingdom. He recently completed a UK-wide study examining the use of reversal agents for direct oral anticoagulants, known as the Rapido study. This work was delivered through HemeStar, a UK-wide network of hematology trainees interested in research. Dr. Buka's current work focuses on improving decision-making for patients who may require DOAC reversal, including how urgent drug levels can be incorporated into clinical workflows. In addition to his clinical and academic work, Dr. Buka also hosts the podcast Don't Just Read the Abstract, which focuses on recent advances in medical and classical hematology. So welcome, Dr. Buka. We're very happy to have you as a speaker today for our National Thrombosis Seminar. And just a brief reminder before Dr. Buka starts that there will be a 10-minute question and answer period at the end of the presentation. There's a submission box for your questions if you want to put them in there, or you're also welcome to turn on your microphone and ask us directly. But with that, I'll now hand over to Dr. Buka.
Good afternoon, everybody from the other side of the Atlantic. So, this is Sir Peter Medawar. He said, "I cannot give any scientist of any age better advice than this. The intensity of the conviction that a hypothesis is true has no bearing on whether it is true or not. The importance of the strength of our conviction is only to provide a proportionally strong incentive to find out if the hypothesis will stand up to critical examination." So hold those words in your head while I talk through anticoagulant reversal, focusing on DOACs. I do have some disclosures, the most relevant here being AstraZeneca, who funded the Rapido study that I'm going to talk about as a hands-off externally sponsored research grant. And obviously, many of you will be aware that AstraZeneca make, or used to make, andexanet alpha. There's a few other disclosures in there too. Okay, so before I rumble on about DOAC reversal, it's probably worth just running through who I am. Sporting this lovely HemeStar t-shirt when it was brand new. So I'm currently an academic clinical lecturer in Birmingham. I did a PhD finishing last year that focused on VIT and heparin-induced thrombocytopenia, very much lab-based, but alongside that I've been working on DOAC reversal for a number of years. My clinical training finishes at the end of this year and planning on continuing as an academic clinician and going into trials. I also chair HemeStar, which is the organisation that we will talk about, and I'm really thrilled to be speaking to CanVector, which seems like a highly productive model network. And the trials element is something we're definitely looking to emulate. In the UK, we also have the UK Trend Network, which is part of InventVT, and I'm on that committee too. So it's something I'm very passionate about. And I have a real affinity for Canada. I've got family on the West Coast. My aunt and uncle were doctors out in Edmonton for the best part of 30 years. And I did my elective there, a couple of weeks in Edmonton, then a couple of weeks in Jasper, where I had a bit of a fight with a ski hill. and broke my face in several places. So there's definitely part of Canada in me, and definitely parts of me in Canada, quite literally. Right, let's move on. The problem. So DOACs, as you will all be aware, and I use the word DOACs here, knowing that the ISTH prefers to say oral factor 10A inhibitors, because I'm including dabigatran in there. So we're talking about apixaban, edoxaban, rivaroxaban, dabigatran. I'm just going to use the word DOAC. So these drugs emerged onto the scene 15 years ago, quickly surpassing warfarin, and in that time their use has ballooned, really. So conservative estimates suggest that there are about 50 million people in the world taking anticoagulation. That's probably higher. We think there's a roughly 1.25 million people in the UK taking anticoagulation out of a population of 60 million. So roughly 1 in 60 people in the Western Hemisphere are Western world probably on anticoagulation. As again, you will know, these drugs still have a risk of major bleeding between, well, quotes, the figures vary, but between 1 and 3%, if we go 1 to 2%, which suggests that every year 1 million people in the world have a DOAC-associated major hemorrhage, and that's forgetting all the people who have clinically relevant non-major bleeding. Probably around 0.5% risk of intracranial hemorrhage or intracerebral hemorrhage, being the most common type of intracranial hemorrhage and the one that's associated with the highest morbidity. So you're looking at roughly 250,000 to maybe 500,000, 500,000 intracranial hemorrhages related to a DOAC every year. And that's actually similar to the estimate of 250,000 deaths a year due to stroke secondary to atrial fibrillation. So this is a really, really significant problem. And I want, in this little talk, to help you see past some of the dogma. Hopefully there's a few moments here that will make you think, ah, yeah, why do we do it like that when there's very little evidence? So what is the evidence? Well, if someone bleeds on apixaban or rivaroxaban, there's clearly a rationale for wanting to try and reverse that anticoagulant effect and restore hemostasis and improve outcomes. Yet, 15 years after the DOACs came into, or even more, 15 years after the DOACs came into clinical practice, we still really don't know what we're doing. We still really don't know how to treat these patients optimally. We've done one randomized controlled trial, and that was the ANNEXA-I study, which many of you have heard about, which randomized patients with apixaban or rivaroxaban related intracranial hemorrhage, the vast majority being intracerebral hemorrhage, to andexanet alpha, this novel decoy factor 10A molecule, or usual care, the majority of which was PCC. And spoiler alert, the trial showed that there was a substantial reduction in the number of patients who had significant hematoma expansion at 12 hours, but the trial was underpowered, or wasn't powered for mortality, disability, real hard endpoints that matter to patients. And really worryingly, that drug led to stroke. So roughly 1 in 10% risk of ischemic stroke, compared to about 5% with PCC. And actually, if you look in the FDA submission, there's even more events. So again, as many of you will know, andexanet's been pulled from the US market. My understanding is you never had that drug in Canada at all, although you can correct me if I'm wrong. We do have andexanet in the UK. It was only ever funded for gastrointestinal bleeding in England, but we've just written a BSH position statement on andexanet to say essentially this drug is associated with a really high risk of thromboembolism. If you're going to use it, you really need to be aware of that risk. And we wonder whether regulatory decisions are imminent. So, in grand total, if we take 500,000 patients a year who have a major hemorrhage, we've only randomized 0.05% of that, because 503 patients were included in the ANNEXA-I study. Yeah, of course, there were other trials and other prospective studies, but none of those were randomized. So in grand total, 503 patients for such a significant problem seems absolutely nuts. And now we're losing andexanet, and andexanet's not going to be used going forwards in any serious volume. We think about PCC. So PCC emerges as a treatment for DOAC-associated hemorrhage very organically, extrapolating from the warfarin era, where PCC containing clotting factors 2, 7, 9, 10 essentially just goes in and replaces those missing clotting factors. There are some preliminary preclinical data suggesting restoration of thrombin generation with the DOACs and PCC. So it's sort of emerged into clinical practice, but very organically. There have been no trials. And actually, the detail on this slide isn't important, but what it is I've taken the vast majority of observational studies that have included comparisons between PCC and doing nothing, or at least not giving any reversal agent, and shown the outcomes. And there's only one study that's shown duration of bleeding has decreased. There were a few patients in the NXRI study. Again, no difference in hematoma expansion between doing nothing and giving andexanet alpha. I just included that there just as doing nothing and giving PCC. So the summation of the evidence is that although it's very intuitive to want to give something to try and reverse anticoagulation in these patients, no study has shown real tangible benefit. There's so much bias and confounding. It's very difficult to tease out what the reality is. So what if we don't do anything about this? What if we continue just to rumble on with this lack of clarity and treat patients with PCC without any knowledge of what we're doing to people? What about that next patient that you see in the emergency department? Do we want to be standing here in 10 years' time going, well, we could have done something about this. We could have generated better evidence, but we didn't. That would be 5 million people worldwide, at least, who have been treated or have come in with anticoagulant-related heart bleeding where we just don't know what we're doing. You could argue, why bother studying PCC and other reversal agents? Because we will have novel reversal agents, and I think we will. We don't have these right now, and andexanet's failed. And I think a lot of the studies that needed doing with PCC have been put off because of andexanet being around. But clearly that lesson is that you can't afford to wait when the evidence needs generating. We can't not do trials because we think that PCC is going to be surpassed by the next big thing, by something that's technically and probably narratively better, but really unproven. So I don't want to be having that conversation with the patient again, neither in counselling for anticoagulation or in the heat of the emergency department when the worst happens. And then we have to ask ourselves the question, well, what if reversal doesn't work? So the elephant in the room here is that there is no evidence that PCC versus doing nothing changes anyone's outcome. And it is entirely plausible for various reasons that giving a reversal agent, even the best reversal agent, which might be a novel agent we've not heard of yet, actually changes outcomes for the vast majority of patients. That's entirely plausible for a number of reasons. Warfarin causes an absolute deficiency of clotting factors, and those can simply be replaced. And without reversal with warfarin, you have 36, 48, many days worth of anticoagulation, whereas the DOACs wear off very quickly. The half-life of rivaroxaban and apixaban, ballpark 10, 12 hours. And in trials, in an XRI, over a fifth of patients had drug levels that were pretty low, under 75 nanograms per mil. More on the drug level cutoffs later. But you can see that we are treating a lot of patients who may well not benefit. And in general, even the ones that might benefit, there's no evidence that we're doing the right thing. So where do we need to get to? What are the possible positive outcomes? We've ended up in this situation. Just to summarize this part, we've got no high quality RCTs. There's a poor consensus about what we do. There's erratic dosing, random cutoffs of drug levels, conjecture, expert opinion, powerful narrative, medico-legal concerns, and toxic therapies. And I think the overarching theme here is that there is over-treatment based on the principle of first do no harm. And I think much of what we do in DOAC reversal boils down to the power of narrative. And this is my son in the middle around a campfire the other week. Actually, if you've heard of Glastonbury Festival, Glastonbury Tour is just in the background there. But I put this picture in because kids and humans, we all love stories. We've all evolved to love stories. It's universal. The presence of good storytellers is actually, and this is a really interesting study, is associated with increased cooperation. Skilled storytellers are preferred social partners and they have greater reproductive success. That's why I've been working really hard on storytelling recently. But direct reversal boils down to this, and it's a very powerful story. We've got a patient who's had a blood thinner, who's bleeding because of that blood thinner, and it makes so much sense to want to reverse it. And it makes so much sense that that would be a good thing to do. But we actually don't have the evidence. So where do we want to be? Where could we end up? Well, in 10 years' time, I'd love it if a patient comes into the hospital where we know that giving a reversal agent is likely to have a net benefit and there's unlikely to be harm. We know which patients are most likely to benefit. We know what dose of reversal agent to give. We know what the impact of doing a drug level is on the clinical workflow and the decision making. And we know, importantly, what drug level is important to guide decisions. Ultimately, as I've said, we want to be able to look our patients in the eye and tell them that we did everything we could in the cold light of day right now to make sure we were prepared for this, to make sure that we could give proven treatments to them in the future. So I'm going to talk to you about what I've been trying to do in the UK and what me, along with hundreds actually of collaborators, have been trying to do in the UK to try and set the scene so that we can dissect what's going on the ground level without the colour of trials and protocols, but really understand what's happening in the real world, how these drugs are used and the limitations and what happens when we try to change things. And this is where the Rapido study came in. So Rapido was a national audit, and actually it came about because in the UK, several years ago, when Andexanet got approved and it got funded in the NHS, Scotland decided that they would give reversal agents, they would give Andexanet to anyone with major hemorrhage, whereas in England, it was decided that it would only be funded for GI hemorrhage. So I thought, well, there's a brilliant natural experiment here, where we compare patients in Scotland who receive Andexanet for ICH potentially, versus those in England who receive PCC. And similarly, we can do it before and after, where some patients before had PCC, and after we get Andexanet, they get Andexanet. In reality, we didn't have many Scottish patients, so that sort of failed. But we do have some really interesting observations. So we gathered data on 2,265 patients. And this was the study that was published a month or two ago. We had over 1,000 patients with intracranial hemorrhage, around 900 patients with GI hemorrhage. And our primary outcome was to look at how many of those patients had major bleeding. Now, intracranial hemorrhage, as you all know, is by definition major bleeding. So excluding those patients, only around 80% of our patients had ISTH criteria for major hemorrhage. That went up to about 85% if you included more liberal criteria like hemodynamic compromise. But in terms of actual drop in hemoglobin, which defines major hemorrhage, only 79%. So 1 in 5 patients with non-ICH related major hemorrhage were non-major, which suggests that we're probably over-treating. So that's your first fifth of patients who we're probably over-treating. And then we were able to look really closely at timings. So our median time from admission to reversal agent administration was 4.5 hours. So quite a long delay, really. And actually, really interestingly, the median time from last DOAC dose to reversal in the patients for whom we have that data was 16 hours. Now, those of you who know the data will know that the cutoff in an XRI for inclusion was 15 hours. So over half of our patients are outside that cutoff window. And in an XRI, 25% of patients had low drug levels. So we're giving these reversal agents in the real world to people who don't have major hemorrhage and to people who are massively long time post-dose, and we're giving them quite late. So the question is, who do we treat? And I think you can probably tell from the way I've explained things is that I'm pretty skeptical about reversal. So I'm skeptical that it does very much at all. Now, I'm happy to be wrong, but I think we should come from a position as where we assume no benefit until that's proven, especially with drugs that can cause thrombosis and cause harm. So for me, the key thing here is to try and make use more precise, make our patient selection more precise, So how do we do that? Well, at the moment, we're sort of playing around in the dark. We don't know which patients have therapeutic drug levels. So yeah, we can identify major hemorrhage from parameters and things, but we can't really identify patients who have therapeutic drug levels. Now, of course, some hospitals can do urgent levels. But actually, when we look in the Rapido data, and there's some issues with this data, so don't take this as read. But really interesting, there's absolutely no correlation in the 200 or so patients that have a drug level between the drug level and the reported time from last anticoagulant dose. So this is dogma. It's dogma that, these have a predictable offset, predictable half-lives. We know that if we use a 15-hour, 20-hour, 24-hour cutoff, we're in a good place. I really don't think that's true. And there's some evidence from the German registry showing where they took patients who were admitted with major bleeding or needing major surgery and took serial blood samples, where they show that the half-life of the drugs is pretty unpredictable, actually, in patients who are sick. I think this is a really important slide because I think it blows some of the dogma out the window. So we can't continue to rely on time from last dose because firstly, it leads to inclusion of patients who aren't therapeutically anticoagulated. But also, if we use a cutoff of 24 hours, you can see that many patients in this figure who are 24 hours post-dose or further have high drug levels. So we're under-treating the wrong patients, we're over-treating. We need more precision. So for me, drug levels are the obvious answer, and they've obviously been touted for a while. So are they feasible? I think so. And I'm going to show you in a minute some more data from our local work. The feasibility is down to, is there an assay? And our labs can definitely run anti-10A activity assays. We can debate point of care, but again, for various reasons, I don't think that's the answer. But if you have plasma in the lab, running a DOAC level is easy. It's quick, it's automated, it's easy. It's not a barrier to having more information about these patients. So the key question, I think, and this is the one I always get handed back to me, is, well, Rich, there's no time. Someone's needing urgent reversal, there's no time. Well, you can see from the Rapido data that there's a lot of delays. And I've been looking locally in our hospital. These are 40 patients who had reversal for major hemorrhage, or for hemorrhage at least. Now, the x-axis is time. The y-axis, these are all individual patients. And I've got color coding from reported time of last DOAC dose, when they had a coag sample taken, so we use blue citrate bottle, when those coag results were available, so that's usually an INR APTT, when they had their reversal agent prescribed, and when the reversal agent was administered. So you'll see some pretty horrific data in here of delays between reversal and prescription and administration, but I'm not going to focus on that today because that's our own problem. What I'm just going to draw your attention to is a couple of patients here. So you can see these are two patients. They've had their DOAC looking like 5-6 hours ago. And you can see in orange the coag sample being taken, the reversal being prescribed, and the reversal being administered. Sorry, the coag sample being taken in green. And you can see a difference between the coag result being available of 2 to 3 hours. So you've got that information. You've got an INR and an APTT in the lab reported 2 to 3 hours before the reversal agent is even given. And actually across the cohort, the median is 3.2 hours. 90% of our patients had a plasma sample sent to the lab, and 70% had a prothrombin time result available before reversal. So we could have definitely had DOAC levels on these patients. We don't, because our hospital's not doing that at the moment, although we can. So I think there's definitely time. And then the final question here is then, what are the consequences? Well, okay, we need to ask ourselves, if we start doing urgent levels, could we cause more delays? Could we see a change in use? Could we have a patient where, okay, someone calls me and says, hi, Dr. Buka, it's doctor in emergency department. We've got this patient who's bleeding. What do you think? And I might say, well, they're not too bad. But if we get a drug level that shows that their DOAC level is 200 nanograms per mil, is that going to change my management? I actually don't know if that would change my management. And I'm sure many of you could ask yourselves the same question. And I'd be really interested to see what you think. And I'm looking to try and do some work to try and harness everyone's opinions on that. And finally, can it change patient outcomes? So we've got to set in motion a train that can try and answer some of these questions. So this is what I'm working on. Firstly, I'm working on a UK study that is similar to Rapido, but looks in real granular detail about timings. We're going to look at patients who are in centres who do urgent drug levels, and we're going to look at patients who in centres who don't, and we're going to compare. Also within that, I want to try and predict drug levels better. So not just using time from last dose, but can we use other demographics to potentially predict drug levels? So this is some feasibility work. I don't know if that's going to be possible, but it'd be nice to have a little bit more precision. Because in reality, not everywhere in the world is going to be able to run an urgent apixaban level at 24 hours a day. I also want to do a modified Delphi consensus to try and get a bit more consensus on things like, okay, if you have urgent drug levels available, which patients are you going to use them in? Are you going to use them in everyone? Or are you going to use them in patients with non-ICH who are greater than 8 hours post last dose? So we really need a modified Delphi to try and bring some consensus, which will then form future stuff. So what I'd really like to do is an observational prospective study or even a cluster RCT where an institution, a hospital that's not using urgent drug levels to guide treatment decisions can switch over to that protocol and use the modified Delphi to try and inform what that protocol would look like. There's also some really interesting ancillary questions here. I think there's some really interesting medico-legal questions. There's also some health economic issues and also some qualitative stuff around restarting anticoagulation in patients who have nearly died because of their blood thinner. But as I mentioned before, what I'm really jealous of with CanVector is your ability to do amazing trials. And this is what we want to do. We want to use our growing network in the UK to lead into more impactful change and trials. And the two trials that I need doing plus novel agents. The first trial that I think needs doing is PCC dose. So either you take all comers, low dose versus high dose. That could be fixed dose and weight adjusted. We haven't got to that yet. And again, Delphi would probably help us with that. I think that's really, really important. I think that trial ideally would have been done 10, 15 years ago. It hasn't. People might argue it's too late. I don't think so. I think the lessons that we've learned about Andexanet, and I think the novel agents are a long way off. I think we have to do this work because that will allow us to interpret the usual care arms as well. I'd also love to do liberal versus restrictive drug levels. So if you're in a hospital that can do urgent drug levels, randomizing individual patients to receiving reversal agent at low drug level, let's say 50 nanograms per ml versus 100. These drug level cutoffs that many of us are familiar with, 30, 50, 75, aren't based on very much. And we don't know whether off from reversal at different levels it changes anything. And finally, novel agents, which again we're coming and I've alluded to. So the whole point of this is that it will allow us to be rational. The problem with reversal and these decisions is it's very reasonable for us as clinicians to say, okay, I've got a patient in front of me who's bleeding. I don't think it's reasonable for me to say to that doctor in A&E, in the emergency department, sorry, I don't think it's reasonable for me to say, well, look, guys, there's no evidence. You really shouldn't give this drug when you're faced with that person. It's such a powerful, powerful thing, powerful story that we tell ourselves that we should do something in that situation. We need better evidence to be able to be rational and do something that feels unreasonable. I hope that makes some sense. So just like to acknowledge a few things, and in the last couple of minutes, I'll touch on HemeStar, which is this organisation I chair. So HemeStar was set up in 2017 as a brainchild of people who are leading the National Institute for Health Research haematology section, because we realised that the parts of haematology that are not cancer, and we call that medical haematology. I know people are calling it classical haematology and all sorts, but we'll go with medical haematology for now. We know that medical haematology was poorly served by research, and also we were trying to encourage people to get into medical haematology because we were losing a lot of great people to lymphoma. So that started as a brainchild of that group, and it was led by Dr. Pip Nicholson, who's my boss. And it grew and grew and grew, such that we've done several retrospective studies like Rapido. We've contributed to trials. One of the trials we contributed to was the flight study in ITP. But the thing that I'm most proud of, I think, in the last few years is that when the ISTH was in London, there was a legacy fund. And we applied for a small amount of funding that we directed towards an international collaboration with the Nigerian Society of Hematology and Blood Transfusion. And we are very passionate about networks. And we're very passionate about how a network can bring people together, it can form connections. But we're also passionate about how a network should develop. And we really think that a network emerges as a result of work. We don't think a network, you can have a network first and then do stuff. So we have tried to encourage a similar network to Hemstar in Nigeria, which is now called HemRhine. So we've been able to fund a couple of fellows in collaboration with the Nigerian Society. And those guys have actually pulled off some really cool projects. They've both been, so Aisha on the left, Michael on the right. That's sort of top right, Aisha, the selfie with me in the bottom right. Those guys have both been to British Society for Hematology. They're doing amazing things. And we've developed a really, really nice friendship between the two organisations. So if you want to find out more about Hemstar, you can go to hemstar.org. I don't think I need to preach to CanVector about the power of networks and how it works. But again, if you're more interested in the trainee angle, then feel free to reach out to me. I'm more than happy to discuss at any point. So just a few further acknowledgements. Obviously, I've mentioned Pip. Bicops, who are our professional data management team, and Amazingness in the University of Birmingham that help with Rapido, AstraZeneca for funding Rapido, the Leukemia Unit Appeal Fund in Dudley, again for helping fund Rapido, the NIHR who fund me currently, and the British Heart Foundation who supported me through my PhD. I'm going to finish there. I'm going to leave this shameless plug here that Joe alluded to. Pip and I have been in this podcast for a couple of years. We love it. Pip says it's his favourite part of the week. Well, not the week, part of the month. I'm not sure that's because he likes me. I think it's more because he gets to geek out on things. But if you want to find that, we also have a newsletter on everything medical hematology that's free. And we would love to hear your feedback. So I'm really looking forward to any quick discussion. Again, feel free to reach out to me if you've got any other thoughts or queries in future. I'm going to leave that there.
Thank you very much, Richard. That was a really, really great talk. Some interesting data that you presented. So we'll move on to questions, and I, as you know, I'm interested in this particular area. So I have a few questions that I was thinking of as you presented your data. So I'm just wondering, I mean, maybe to be the devil's advocate, because I've thought about this concept that you put forward about, you know, what do we want to get out of providing a reversal agent to patients who have bleeding. And it's an interesting philosophical question. You know, it sounds to me like you ultimately want to see, you care about, you know, functional status, for example, at 30 days, 90 days, right? Does it actually improve what ends up happening to patients longer term? And I agree with that. And I'd say the field as a whole probably agrees with that idea, right? That's what we want to see. And I think that's what people were disappointed with the ANNEXA-I results, right? As we didn't see improvements in functional outcomes. But I guess, again, to be the devil's advocate here, I mean, do you think there's any value at all in demonstrating an improvement, even with ANNEXA-I, right, with the hematoma volume, for example, or with, you know, with definitions of hemostatic efficacy? Because I just think, I used to think of it this way. I mean, I've studied PCC quite a bit, but I always used to tell people before we were aware of the thromboembolic risk that if I was on apixaban and I had intracranial hemorrhage, I'd probably want to get andexanet alpha. Maybe not anymore, but previously I did, because I cared that, you know, if I was bleeding into my brain, I want that to stop, right? So I'm curious about your point of view on that. I mean, should we give any weight to shorter term outcomes? And then if we're focused on longer term functional outcomes, do you think we're ever going to be able to demonstrate that?
There's a lot in there, and I will definitely miss things out in this answer. So I think hematoma expansion is a really compelling surrogate outcome because it's one of the key drivers of poor outcome. So we know that if you have significant hematoma expansion, you have a worse outcome. And obviously, it's one of the few things that's actually modifiable. You can't modify someone's initial bleed volume. You can't, you can modify blood pressure. That's another thing you could do. But ideally, as a target of something to do, then it makes really, really intuitive sense. The trouble is that we don't have proof that if you artificially limit that, then you improve the outcomes. So although it's compelling, we've never proven that it's a we've never proven that it's we've never validated it as a surrogate outcome. Now, I've thought long and hard about this, and an XRI, it's really difficult to power a study adequately to show mortality benefit. You need a pretty large study. I think the FAST trial, which was 2008, Mayer et al., New England Journal of Medicine, that looked at recombinant factor 7A in patients with non-anticoagulated intracerebral hemorrhage, they actually showed at 24 hours a reduction in hematoma volume versus placebo. But actually at 72 hours, that statistically significant reduction disappeared. And obviously that was associated with thrombosis as well. So I would prefer to see, I think if we're going to do hematoma expansion, my feeling 12 hours is far too early. You need to see final bleed volume. That's what you need. I think that's a reasonable compromise. And if you can show me that a drug limits final bleed volume and doesn't harm someone, then I'm a little bit more sold. But I think it's really hard in DOAC-related bleeding to win on trial. I think it's going to be really hard. I think this is why, an XRI didn't go for that, because you'd need a really large study, because I think it's only a fraction of the patients who probably stand to benefit.
Yeah, and I think, I mean, you need to get in early on, right? But then I think the trade-off is trying to do a high quality randomized controlled trial in this patient population and implementing this complex intervention early on. You inevitably may end up with some selection bias, right? Where trying to get these patients into I mean, I forget the exact sample size of an XI, but they had recruited all around the world, right? And there were probably a lot of those centers that had fairly few patients that ended up being recruited. But and then, so maybe as a follow-up question as well, I mean, you seem fairly keen on the idea of DOAC levels. I like your comment about this dogma of DOACs having predictable pharmacokinetics, and I take the same view that it's interesting that over the past 15 years, pretty much every paper that's focused on DOACs in the introduction has that sentence, right? The DOACs have predictable pharmacokinetics. We recently wrote a commentary on this exact issue where that position is becoming increasingly difficult to sustain. But just from the point of view of anticoagulation reversal, I mean, how do you see that? You mentioned that a lot of centers don't have ready access to it. Do you see that maybe changing? And what do you think would be the role of point of care testing in this context?
I'll deal with the last question first. So there is a lot of interest, obviously, in point of care because, by all intents and purposes, it's quicker. The trouble is, I think, that the volume is low. So I don't have evidence for this, but I feel like if point of care was a goer, we'd have had it. We'd have had it ages ago. I think the problem is volume. So in our hospitals, we've got a big multi-site hospital, 3 big emergency departments. We reverse a patient every day, pretty much. So each emergency department is probably dealing with this like twice a week. So if you compare that with a blood gas analyzer it's a real workhorse, it's getting lots and lots of action. I think trying to do point of care is really hard. Now, clearly there are urine things and whatnot. It is an option, but for me, the lab is so much better set up to make sure that test is available, it's reliable, it's there all the time, it's interpretable, and the clinicians don't have to know anything about it. All they do is have to send the blood. So I'm not sold on point of care, but again, happy to debate it. And again, there's not much evidence. Remind me of your first question.
Well, I was just asking how would you see DOAC levels in general, not just point of care, how would you see them necessarily informing? Because you had
Yeah.
those three features, right? And I'm more interested in the consequences aspect. Like, how do you
Yeah.
see it being used?
So I think we're a beautiful place where I just don't know. And I think that's really cool. I'm coming from this. I think I'm trying to take a scientific viewpoint of not really being invested in any answer. Now, clearly, I'd like to go with an urgent DOAC level guided strategy for deciding, but I'm very open-minded that that might not work. But the key thing is to study it. So the key thing is that we've got hospitals in the UK have been doing this for years and years, 4 or 5 years, and have never gathered their data. And obviously the numbers are fairly small, so we can pull together through Hemstar and do this. But I just don't know. I think there's going to be patients where maybe asking for an urgent level delays things. I think you can see adverse consequences of not only delay, but changes to decision making, and it could result in harm. In patients who need urgent operation, for example, if you've got someone who needs a fracture neck of femur repair and you're doing a PIC span level and it's high, and you wait longer, then that person may well have a worse outcome than if you just cracked on and done the surgery. So I think it can go both ways. If I had to bet, if we can get this right and on a net scale, I think you will see advantages both in reduction in use of PCC, but also more precise use. So you're going to then give it to people who are a long way post last DOAC dose, but have a high level, and then taking it away from the people who just don't stand to benefit. But yeah, I mean, it could be an absolute wild west, and I think it will be massively variable what happens across different hospitals, different times of day, different clinical teams. It's it's for me, it's really worrying that we have this huge blind spot.
Yep. Yeah, absolutely. I mean, it's interesting. I probably mentioned the study to you, but we did a prospective observational study here in Ottawa, and it has been accepted for publication. So I'll maybe just mention that we did see differential response depending on the pre-PCC DOAC level, meaning that the effect of PCC on thrombin generation was blunted, and there seemed to actually even be a ceiling effect where if your DOAC level was above a certain value, you weren't really seeing much of an effect at all. So that's just our local data here, but I do think that might be an interesting way of using it as well, as seeing how the pharmacologic effect of whatever reversal you're using might be modulated depending on the mechanism of action, right? Like with IndexNet alpha, it probably didn't really matter. With IndexNet, I was thinking as well that it's useful to avoid giving it, right? And I know you mentioned that, but if I had a PIC span level of 31, I'm not sure I would want to face the
Yeah,
potential risk of stroke, right?
yeah,
But
yeah. No, I agree with you, but I think from a purely philosophical point of view, I think that also applies to PCC, which is a pretty dirty drug. It's probably full of all sorts of microvesicles and inflammatory stuff, and we saw that in the patch study that if you start giving platelets, you start giving thromboinflammatory stuff, you have black swan consequences where you couldn't necessarily predict that. But if you look at overall mortality, you might see an increase, but not really understand why. So I just worry that the stuff there are a lot of unknown unknowns.
Okay, fair enough. And I was just reading there's one question here from a J Ray. So asking, so while we understand that DOACs do not alter fibrinogen levels, they do alter fibrin formation. So do you have any new insights into the use of fibrinogen replacement in DOAC-related bleeding in the absence of hypofibrinogenemia?
I'm really sorry. I have no new insights. I have no insights whatsoever. Do you, Joe?
No, no, no. Yeah, I mean, I was just thinking of that as I was reading it. I'm not even aware of any. I mean, off the top of my head, I can't think of any specific studies that have, specifically looked at that in detail, other than again massive bleeding and then consumptive coagulopathy, dilutional coagulopathy with hypofibrinogenemia. So,
I mean, you
uh,
can obviously you're going to give. It's almost like you're trying to rebalance hemostasis, and no matter how you do that, the problem is going to be dose. And again, it comes down to if you've got a drug level. If you've got a drug level, then maybe you can tweak that dose. But we have to do that in a randomized trial. You have to try and show that that kind of precision is worthwhile. I guess the other problem with fibrinogen is that there's that risk of thrombosis as well, especially if you get it wrong. So again, I mean, it may well be an option, but I think we have to try and prove these things.
Yeah. I think there's a similar narrative around tranexamic acid, right? And do we give it? Do we not give it? I think there's so little evidence for anything that we do in this clinical setting, anyways, that I typically recommend it unless I have a reason not to. But it's the same idea where there's not really a lot of specific data related to it. It looks like Anne Holbrook has have your hand up, and I don't know if you wanted to ask us directly.
Yeah. Thanks very much. That was very interesting. Richard, if you can indulge me for a minute, I'm in Canada. So I'm actually clinical pharmacology and internal medicine in Hamilton, and these patients would come in under me, and then hematology is consulting. So I'm particularly interested in the regulatory, not so much the medical legal, but the regulatory. Maybe Joseph can comment. But I see that andexanet is still listed at our drug products database, which means it's still available in Canada. I wondered what's the prediction the other Canadian experts know. Is it likely to stay? Will it leave and go special access, or just will leave entirely? What do you folks think?
I can maybe comment on that. I mean, I'm not aware of any specific or information, so I don't really have a sense of that. I've wondered that as well. The issue is in Ottawa, we've never really used it. I mean, I've heard that in Montreal, for example, they had access to it in the emergency department. I don't know about in Hamilton how often you guys ended up using it. But yeah, it's an interesting time point right now where I'm not sure what's going to happen, and interesting in the sense that usually if the FDA gives a decision, it's fairly influential, right? So I'm not sure, Richard, if you have any other insight from a UK perspective.
Yeah, we write this BSH position statement, and we've had to write it in such a way that it also protects colleagues who choose to use it. So we've tried to highlight the very high thromboembolic risk, and I look at this very simplistically and go, well, there's no evidence of clinical benefit. There's definitive evidence of harm. We really shouldn't give it. But clearly, I'm just one person and one brain, and there are other perhaps very valid reasons to perhaps give it. And there are definitely anecdotes of patients exsanguinating in front of people and giving andexanet and all stopping. And I certainly wouldn't be using it for ICH. I think that ship's sailed. I think it's very difficult to show benefit. I mean, you look at the animal data. Some of the best data, I think, for andexanet is looking at pig laceration, liver laceration models, and it is very effective at preventing death due to exsanguination, but not vastly more than PCC. So I think, look, everyone makes their own decision, and I think you have to make that decision at an institutional level as well. There are definitely hospitals in the UK that have taken it off formulary, and they've gone through the legal process to do that. Because I think you have to take that decision away from the person who's in front of the bleeding patient. That's really hard to look someone in the eye and go, I've got this drug, but I'm not going to give it. So you've got to take it. You've got to take it off. If that's what you believe.
I think you're right. I mean, I think the other thing that's a little bit influential is reading between the lines. FDA said they could not come to an agreement with the manufacturer about even a further study. So they were obviously, not impressed at all overall. Yeah. Thank you.
Yeah. Thank you for the question.
Thank you.
So I think that I don't see any other questions in the chat, so maybe we'll leave it there. Caleb, I don't know if I can. Oh, perfect. So so thank you very much, Richard. That was a really great presentation and a great discussion. So just a friendly reminder that the recordings for these sessions are available after the talk at the link that you see here. Just another reminder again that this is our last session for the year, but we will be back next year, probably in October or November with next year's seminars. So thank you guys again, and thank you, Richard, for taking the time to present to us.